If you have heel arch or Achilles tendon pain, I'm going to teach you in the next 20 minutes how to get rid of it forever. I promise. Hi there. My name's Dr. Richard Loninger. I'm a foot and ankle surgeon from Manhattan, New York. I've been practicing for about 29 years, and I'd like to speak to you today about a very common ailment that I see in my practice. It's an ailment that is fraught with complications and has a very high failure rate. I see lots of patients with heel pain who have received the gamut of care. They've received injections, could be up to 3, 4, 5, 6, 7 injections, arch supports, oral anti-inflammatories, steroids, been to extensive physical therapy care and still not doing well. Or maybe they have a recurrent problem. It gets better, it resolves, and then it returns again. It's a very common presentation in my practice. There's a problem there, and that problem is very commonly that 90% of physicians that I see are not treating the entirety of the complex. It's a complex of two pathophysiological problems. However, I find that the vast majority of individuals are being treated for only one of those problems. And this speaks to the reason as to why we have such a high failure rate with this condition. So I am a surgeon, but this video by no means is going to establish a patient-doctor relationship, and it's strictly instructional, educational. I want to address those patients that have failed care and still continues to have a chronic problem, and I'd also like to address those patients that are of new onset, just developing this condition within the last couple of weeks, the last couple of months. I've had patients who have had this problem for up to 12 years. So it can be quite lengthy when we have this issue. This issue can become quite serious and really diminish our ability to be functional and to maintain our activity level. So let's first start with the condition that we get right, that most doctors get right. And that is what's called plantar fasciitis. So plantar fasciitis is one side of the equation only. Plantar fasciitis is an inflammatory condition of a ligament or tendinous structure, a band at the bottom of the foot that connects at the bottom of the heel, and that heel delivers that plantar fascia as almost like an exercise band. It's the width of the foot. Its full thickness is about 2 millimeters in thickness, and it originates on the plantar surface of the heel, the very bottom of the heel. That structure microtraumatically rips and tears. And when that structure microtraumatically rips and tears, it bleeds. When there's bleeding, there's scar tissue. When there's scar tissue, there's fibrous tissue it's morphed into, and after fibrous tissue becomes cartilage, cartilage then becomes bone. And we have the same occurrence that occurs at the Achilles tendon on the top of that heel bone. So we have a problem with the Achilles tendon at the top, we've got a problem with the plantar fascia underneath, and we've got a problem with any of those fibers surrounding and enveloping the heel like a bird's nest. The Achilles tendon inserts on a bony ridge at the very top of that heel. It envelops the heel like a bird's nest and sends out thousands and thousands of fibers on the inner aspect, the outer aspect, posterior aspect, and then inferiorly it becomes the plantar fascia. When we are in a state of rest and relaxation, our foot plantar flexes, and we get a reduction in the tone of that rubber band-like structure, or a reduction in the tone of that Achilles tendon. And when we awake, or after we've been seated for a long period of time at the desk, or sleeping, we get back up, we put a pressure on the foot, it collapses the arch, so instead of the arch being angulated and shortened and contracted, it now lengthens as we get up on it and we propel our body weight forward, and that causes this ligament that runs from point A to point B to be stretched. And it doesn't have the elasticity that it once had because it's being weakened. We'll explain that in a moment. And it microtraumatically rips and tears. And that is what causes plantar fasciitis, or that is what causes the enthesopathy of the Achilles tendon at its insertion to the heel bone. That is the common occurrence of plantar fasciitis, or the enthesopathy of the Achilles tendon. So we're either going to develop pain most commonly in the inferior aspect of the heel or the superior aspect at the Achilles tendon. Common stuff. That is a musculoskeletal entity. That musculoskeletal entity is actually lengthening on itself, trying to fix itself, trying to appreciate the proper tonicity that it should be able to attain. But instead, it tears and rips, and that develops into a chronic process. And it's that chronic process that we're speaking about today, okay? However, let's get into the reason why we fail with this care. Predominantly because the second half of the equation is not addressed. The second half of the equation is the neurological component that occurs with it in every single patient. Some patients, it's quite obvious and easy. Patients with nerve problems, sometimes they're just going to elicit pain that is heightened. The nerve, when it becomes aggravated or inflamed, it becomes, at its most basic presentation, it develops a hypersensitivity. So it causes all ailments, all pathology of the lower extremity to be accentuated due to the nerve being aggravated and inflamed. However, sometimes we will experience things like numbness, tingling, pins and needles, burning, shooting sensations, cramping, pain at rest, and pain at night. These are the pathognomonic markers of nerve inflammation, which means that those hallmarks, those characteristics are only present with nerve inflammation. They are not expressing a musculoskeletal condition. They are expressing the neurological manifestation. Now, the nerve is very important to understand. One, it creates that hypersensitivity. But two, very importantly, it creates the weakness. It creates the ripping and tearing at the Achilles tendon structure or at the plantar fascial structure or any one of those insertions surrounding that heel bone. The nerve creates this condition because when the nerve becomes aggravated or irritated or inflamed, the nerve controls the tonicity, excuse me, of arteries and veins and the amount of blood perfusion that comes to the extremity. When it's irritated, it loses the ability to maintain a tonicity of that vascular lumen. And what happens is we will then develop a dilation. When there's a dilation of those vessels, there's an increased amount of circulation that comes to the extremity. That increased amount of circulation sounds all good and right and something that may help, but it's actually the opposite. It's actually going to wash away those ions that allow for structural stability of those mechanical structures, of those architectural structures, ligaments, bones, tendons. Sometimes I'll see recurrent stress fractures as a result of the neurological phenomena that is causing the increased circulation and washing away those ions that allow for structural stability. So that's what causes the chronicity. So if we've got a nerve problem that's accompanying this heel problem, and again, in every single patient that I've seen in 29 years, I'm able to find that nerve problem. First, we ask whether or not you have any of those pathognomonic markers that we just discussed. And second, through physical examination. Physical examination allows for me to identify a sensitivity of that particular nerve on the side that we are complaining of. What I will first do when I engage you and meet you is I'm going to reach out to your hands and I'm going to compress the radial nerve and ulnar nerve and I'm going to give it a non-painful stimulus with my thumb. I'm just going to compress it very gently, very lightly or moderately. And I'm going to ask you whether or not it hurts. And typically, as long as you don't have a cervical problem or upper thoracic problem, you're going to tell me that up here, radial, ulnar nerve, both sides, fine. No problem whatsoever. I'm going to go down to the lower extremity, do the same exact thing, and I'm going to find that you retract the foot. Sometimes it's easy for me to find that. Sometimes it's moderately difficult for me to find that. And sometimes it's very hard for me to find that. That gradates the degree of nerve inflammation that you have. Okay? Now, another problem, another pitfall is that it's not just a local phenomena that's occurring with that nerve problem. That nerve problem that's creating that hypersensitivity, that's causing the condition, needs or will communicate with the entire system, with the entire neurological system. There is no such thing as one nerve that's aggravated. We have one big electrical grid, our neurological system. It's like a spider's web. If there's an insult anywhere in that system, the whole system feels it. It reverberates, and then we're walking on these nerves. We have a greater demand being placed upon the lower extremity as opposed to the upper extremity in the vast majority of us, stepping 8,000, 12,000, 15,000 steps per day. Some of us are active, we're runners, we're soccer players, we're football players, we're marathon runners. We're putting an exceptional demand on that nerve. That nerve communicates always to the spinal cord. That is where the origin of these nerves come from. And quite often, the reason why we have a problem of our lower extremity nerve or susceptibility or inflammation, slight, moderate, or severe, is because we have a problem at the back. The vast majority of my patients, when I inquire whether or not they have a back problem, the answer is yes. I've had a problem in the back prior, haven't had one in a while. I've seen chiropractors in the past. My back is a problem right now. My back is severely injured. I've got a herniated disc L4, L5. I've got sciatica. And some patients, however, the most difficult ones are those that tell me that their back is perfect. When they tell me that their back is perfect, now I have to inquire and figure out whether or not they have a subtle nerve impingement. I found out long ago I used to have about a 10 to 12% failure rate in treating these conditions to the lower extremity. And that's because I realized somewhere along the line that 10 to 12% of my patients told me that their backs were fine and never had a problem before. So therefore, I never went after the back to try to help the back along with the neurological process to the lower extremity. It's only when I ignored my patients who told me that their backs are fine and told them that they must treat the back with the lower extremity nerve problem that we finally had a breakthrough with that 10 to 12% failure rate. Once I started giving my patients these exercises that restore proper curvature to the spine, we've then alleviated those small little slight impingements that may be occurring at the spinal cord or the nerve rootlets that is subclinical. The back is very well taken care of. That's the core. The core takes care of itself much better than it does the extremity. So we can have a dime's worth of pressure on the nerve rootlet of the spinal cord and not appreciate a thing. But yet we're going to appreciate something down at the lower extremity. So when I'm dealing with nerve problems of the lower extremity, it's imperative that we always go after the back. I liken it to two fires. There's a fire in the lower extremity and a fire up here, the spinal cord. The kitchen, lower extremity, bedroom, spine. If you call me in to put the fire out in the kitchen, very easy for me to do that. However, if we allow for the fire to continue up here, a smoldering little tiny fire that's occurring in the kitchen, and we've avoided that, and we've put it out, eventually that fire is going to recommunicate down the hallway back into the kitchen and recreate that fire in the kitchen. So we always go after the back, and especially in those who have problems and those patients who don't admit problems. It's more difficult to convince a patient with no back problems that it's essential to care for the back while we are caring for the foot, but we do that nonetheless. So what do I do for this condition? What I do for this condition is I do what's called PRP, shockwave, and nerve blocks. What we do is we call you in on a Friday, you get a little medicine in your arm, you're awake, you're conscious, you're talking, you feel like you had 2 or 3 or 4 glasses of wine, and what I do is I put a monitor next to that heel bone. That monitor is going to deliver an acoustic impulse. That acoustic impulse is going to sound like a clapping. That acoustic impulse is going to create inflammation. We're going to augment the inflammatory process that's already occurring there. The body's trying to fix it, and it always is, but it needs help. So we're going to augment that inflammation with the shock wave. It only has about a 50 to 60% success rate, so we have to augment it with something else. So what we do is we do PRP. PRP is me taking blood from you, spinning it in a centrifuge and separating non-healing cells from healing cells. I take those healing cells and then I inject it into the plantar fascia. You don't feel it because you have that sedation in your arm. And what that does, that PRP, is it allows for a more aggressive healing of that ripping and tearing of the plantar fascia. I then do nerve blocks. I address the two pathophysiological features of nerve problems. Nerves become hypertrophied and enlarged. And once they become enlarged, they get further entrapped and squeezed and impinged. And as they get further impinged and squeezed and entrapped, they become more enlarged and they become bigger. So what I do is I give you an anti-inflammatory. I surround all the nerves of the foot and the ankle, and that shrinks them. As soon as there's shrinkage, there's resolution, there's improvement, and as soon as there's a little bit of resolution, there's further shrinkage. Further shrinkage comes further resolution and further shrinkage, and we develop a positive feedback loop. What I do for the second pathophysiological feature, which is our pain gates being open, we have sodium, potassium, ATPase channels. If I put my hand on something sharp, immediately I withdraw my hand. What just happened is these gates opened up, they allowed ions to come in and out, and that told my brain to tell my arm to remove itself from that thorn bush quickly, in a nanosecond. And then the gates fired shut once I've removed myself. However, in patients with nerve pain, the gates are like this. They're slightly ajar, allowing for a constant escape. And that creates the hypersensitivity that we experience. So what I do is I give you a local anesthetic. The same thing that your dentist gives you here in the mouth. Give you a local anesthetic around the nerves. It closes those gates for an hour and a half. Once the gates close, we've reestablished those communications. They would much rather stay like this than like this. This is overexcitation. This is them bouncing off the walls. This is them never resting. They hate that, those nerves. They like the rest, and they like to be in their quiescent stage the way that they were designed to be. So that's how we fix it. After that procedure, you're able to run and jump immediately. You can run for the bus, you can run for the subway. However, if we're participating in athletic endeavors, I ask you to give me 3 to 5 days before we start participating and work your way up. Don't start off where we were before the injury took place. So that's how I treat it. So if you are local, if you are in New York, New Jersey location, I'm more than happy to see if we're hands-on, personalized treatment for this condition with the advanced PRP, shockwave, and directed nerve blocks. I'd be more than happy to see you in that. But I'm also speaking to those patients that aren't in my location. What I've done is I put together my personal clinical outline, my framework of how I just discussed and how I take care of this, and I put it into an educational, instructional link and video for you to take care of this problem at home. And it is something that I offer to you. That link is something that I offer to you for $50. Okay, we all know how expensive medical care is. I give you this opportunity so that you could potentially take care of this without my need, without my help. What it does is it hits on 5 particular areas. One is I give you the exercises for the back that I prescribe to every single one of my patients. What it does is it restores the proper curvatures of the spine. And in restoring those proper curvatures of the spine, it diminishes the impingements. And in diminishing the impingements, it's going to diminish the inflammation of those nerves to the lower extremity. That's the first thing we do. Second thing I do is I give you a secondary physical therapy modality for the lower extremity that addresses the neurological component and the fascial component. Very important in the treatment of this condition to address both. If your doctor's not doing that, that's the problem. The third thing that I do is I give you a nutritional supplement. A nutritional supplement that you can, that when taken is going to put the neurological system into a more balanced attitude and position. I also give you a recommendation for a device that goes inside your shoes. That's not a $400 arch support. It's going to be a $15 device that aids in both the recovery of the plantar fascia and reduces the tension on the nerve. That's essential for my patients. And the last component that I give you, the 5th component that I give you, is a letter to your doctor. So I want you to take certain, or what I do for my patients is I give them certain anti-inflammatories. First of all, non-steroidal anti-inflammatories like ibuprofen, Motrin, Advil, Aleve, Naproxen, they don't work. There are other medications that do work. I don't want you on any heavy-hitting neurological medications like gabapentin. I think that's overkill, and all it does is it reduces the threshold of the nerve to appreciate sensations. and it's not something that fixes it. So this is what I offer you for $50 if you can't come in to see me. So in conclusion, I want you to stay healthy, stay on your feet, and I can't wait until my next video. Thank you very much. Bye-bye.